Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Understanding Mental Health and Poverty, Public Health Strategies to Support People with Low Incomes and Mental Health Needs, presented on behalf of the Association of State and Territorial Health Officials, also known as ASTO. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments into the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends, please take a few moments to complete a brief survey that will show in your browser as you exit the platform. Thank you again for joining us, and we'll now begin today's presentation.
Good afternoon, everyone. I am Caitlin Langhorne-Griffith, ASTO's Director of Injury, Suicide, and Violence Prevention, also joined by my colleague, Allie Maffey, Vice President for Social and Behavioral Health at ASTO, the Association of State and Territorial Health Officials. First, we want to start by giving a little bit of background on the organization. ASTO is a nonprofit organization committed to supporting the work of our state, territorial, and freely associated state health officials, with a special emphasis on furthering the development and excellence of public health policy nationwide. Our primary functions include developing strong and effective public health leaders, improving public health through capacity building, technical assistance, and thought leadership, and finally, advocating for resources and policies that improve our public health's well-being. For today's webinar, we'll hear from colleagues from the Massachusetts Department of Public Health, as well as the Michigan Public Health Institute. And we encourage you to use the chat to share any questions throughout the presentations today. And we will save time at the end for question and answer. As a result of today's webinar, we hope that you walk away with an increased knowledge of the relationship between income and mental health, having learned of strategies and policies for reducing poverty and improving mental health, an ability to discuss the role of public health and healthcare in this space, and finally, having had valuable opportunities to learn from peers with serious mental illness and/or children with serious emotional disturbance. And with that, I will turn it over to the Massachusetts team to introduce themselves. Lindsay.
Hi, thank you so much. Hello, everyone. My name is Lindsay Sagasta. I'm a child and youth violence prevention epidemiologist with the Mass Department of Public Health, and I'll hand it over to my co-presenter to introduce herself.
Hi, everybody. Claudia Catalano, also at the Mass Department of Public Health and the Bureau of Family Health and Nutrition. Thanks for having us today.
Thanks. So today, Claudia and I are going to talk about two public awareness campaigns that we've conducted at Mass DPH about positive childhood experiences as well as financial stability as strategies that health departments can do to promote mental health and financial stability. So we have no financial relationships to disclose, but do just want to make you aware that the awareness campaigns were developed with funding from the CDC. So the interpretations, conclusions, and opinions expressed in this presentation are those of the authors and not the CDC. I'm gonna start this presentation by discussing our Positive Childhood Experiences Awareness Campaign, first by giving a primer about the public health background of childhood experiences and health outcomes, and then going into more in-depth about our campaign. Then Claudia will do the same for our paid family medical leave campaign. So my goals for this section are to describe how childhood experiences driven by the social determinants of health, like economic opportunity and stability, impact health and well-being in adolescence and adulthood, with a clear link that well-being is related to mental health and mental health outcomes. In this background about childhood experiences, I'm also highlighting the role we can play in public health by promoting positive childhood experiences, or PACEs, to improve mental health outcomes and reduce poverty. And then I'll show how we translated this public health background into a campaign. So anytime I talk about childhood experiences, I start with this framing. We really can't talk about anything related to public health without talking about the social determinants of health, those non-medical factors that influence health outcomes. When we are talking today about what people experience, I want to make sure we acknowledge that what those experiences are dependent on the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems that shape conditions of daily life. So for every experience of an individual, family, or community, we need to think about the economic policies and systems, the social norms, social policies, racism, climate change, and political systems that influence who experiences what and to what extent they experience something, both for positive experiences and adverse experiences. So the best way we're going to prevent ACEs, or adverse childhood experiences, and promote PACEs is to work to create the social, physical, and economic environments that promote attaining the full potential for health and well-being for all. Awareness campaigns can help with changing perceptions and raising their awareness and influencing social norms. So a couple slides about the research. There has been decades of research at this point that has established there is a link between childhood experiences and impacts on health and well-being and opportunity in adolescence and adulthood. PACEs are things that promote physical, social, and behavioral development and intellectual capacity for healthy development through promoting safe, stable, and nurturing environments. Some examples of PACEs include experiences that support feeling safe within a home environment or feelings of belonging at school, having opportunities to engage with the community, like through neighborhood groups, sports and recreation, or volunteering, experiences that support feelings of efficacy to make a change within a community, or having economic stability. On the other hand, there are adverse childhood experiences, or ACEs. They block the impact of PACEs by introducing and/or sustaining toxic stress in a child's life, which negatively affects brain development and stress response across the life course. Examples of ACEs include abuse and neglect, bullying, witnessing violence in the neighborhood, discrimination, food or housing insecurity, and many more. And as you've seen in the examples that I've provided, both PACEs and ACEs can exist within a household, a neighborhood, and in the greater society. Studies have linked experiences that impact the brain and stress response throughout the life course to risk-taking behaviors and health outcomes in adolescence and adulthood. As you can see, these are outcomes across the entire field of public health, including injury, mental health, maternal health, infectious disease, risky behaviors, and opportunity, and violence. Mental health includes depression, anxiety, suicide, and PTSD here on this outcomes image, and then opportunities also includes education, occupation, and income. From all of these studies, we know there is a dose-response relationship of the number of ACEs and PACEs and the outcomes. More ACEs increases the strength of the negative impact on risky behaviors or negative health outcomes. More PACEs decreases the risk of risk-taking behaviors and negative health outcomes. And PACEs and ACEs both interact. So the existence of PACEs, when ACEs also exist, decreases the strength of the negative impact. I also like to show this tree diagram. It's abundant in a lot of the childhood experiences literature, but it helps link factors in the community that impact household or individual experiences. So relevant to our topic today, poverty as an environmental factor contributes to being more likely to experience ACEs. Being more likely to experience ACEs then increases the risk of the negative health outcomes, which we know from our previous slide can include mental health and opportunities such as in education or employment. This is just one image we use on our data dashboard about childhood experiences. At Mass Department of Public Health, we also have a data dashboard that shows prevalence of ACEs and PACEs among youth in the Commonwealth. This image is busy, but it is another way, similar to the tree diagram, to think about how positive and adverse experiences in the environment impact a child and family. There are three main takeaways that I just want to name at the bottom of this image. When factors that improve a child's lifelong health are missing or they're blocked by ACEs, it leads to conditions that create barriers to getting basic needs met and access to resources and supports that promote healthy development. When factors that increase toxic stress are present, conditions are created that increase exposure to ACEs, such as increased exposure to the criminal justice or child welfare system, or increased exposure to harm due to identity. And negative factors and the absence of positive factors, increased toxic stress, are also chronic stressors in and of themselves. I close this introduction with this slide just to remind us, as we think about childhood and family experiences, that we are thinking about the many indicators at the individual and family level of the social ecological model, and that we also need to think about the community and societal levels at the same time in order to reduce the impact of trauma on health outcomes like poverty. Changing social norms by leading with the positive, ensuring everyone has the ability to promote PACEs, is one way we can address the implications of mental health and poverty. So we developed a campaign to raise awareness that PACEs can be instilled in every child's life to help combat the impact of traumatic experiences that are linked to adverse health outcomes. One of our links here, mass.gov/the power of positive childhood experiences, is where you can see the webpage live today. This campaign we called The Power of Positive Childhood Experiences, and it had a goal of raising awareness of what PACEs are among parents, caregivers, and community members, and the resources that are available to help them in promoting PACEs. Our primary audience included parents and caregivers ages 25 to 45, families of color, and those living in our named 20 vaccine equity initiative communities in Massachusetts, as we know that these folks have a higher social vulnerability index and have had barriers to access in resources that promote PACEs, including housing, financial benefits, and healthcare due to structural and racial inequities. Through this campaign, we honed into the idea that promoting PACEs and protecting against violence and adversity truly takes a village. So you can see through our visuals to the right of the screen, and we wanted to convey the idea that all members of a child's community are the puzzle pieces that make a child's health and well-being whole. For our messaging, we wanted to convey that parents and caregivers have the skills and knowledge to promote PACEs in their child's lives, from comforting their child and spending quality time together. But at the same time, we wanted to encourage parents to know that they don't have to promote PACEs alone and can connect with their community for support, whether it's talking to their child's healthcare provider about their child's growth and development, or joining a parent support group to have a safe environment they can share their concerns and receive emotional support and encouragement. These images were shown, they were displayed at grocery stores, on Google, and on social media, and the QR code led to our website. So I'm gonna dive a little bit deeper in a brief sense to our PACEs awareness campaign that is still currently online. So when you visited the landing page, it led you to kind of an introduction about the campaign, but then to help better navigate the site for depending on who was visiting, since we did have a broad audience, there were 3 main pages, one for families, one for community members, and then also a resource page. Information for families, this section explains what PACEs are and provides strategies that families and caregivers can use based on the age of the child. So we have a specific section that breaks out to talk about how you can incorporate PACEs at home, but also how you can incorporate PACEs in talking to childcare providers for infants ages 0 to 1, toddlers ages 1 to 3, young children ages 4 to 12, and teens ages 13 to 18. So it follows the developmental spectrum. Diving a little deeper, this information for families page encourages parents and caregivers to spend quality time together and prioritize health and well-being. It also encourages families to engage with the community in various different ways. There's also a page that allows families to look at a section that lists different resources and services available for children and families, specifically within Massachusetts or other national resources. And I can walk through a few of what these resources are to give an example of what's listed. So the parent and caregiver support includes the Parent Stress Line. We also have a Healthy Families Massachusetts line, which provides supports and resources for young or first-time parents with children ages 0 to 3. We have a specific community support line for children and youth with special health needs. For housing, our Executive Office of Housing and Livable Communities Housing Assistance has a reference guide for Massachusetts residents seeking information on housing for families and individuals with low or moderate income. In the mental health category, we have the Behavioral Health Line, behavioral health helpline, which provides 24/7 help available across the state and connects families with crisis services, substance use treatment referrals, and other mental health supports and resources, among many other resources that are listed on this site. It's very comprehensive. And then lastly, the last section is geared towards community members, and it's meant to be very broad. We want to be able to help healthcare providers, home visitors, educators, and school staff, and friends, relatives, or just general community members that don't fit in any of those categories I just mentioned, but do interact with children and families. We wanted them to feel that they have the power to also promote PACEs. There's also additional resources that different healthcare providers or even families can go to, like taking trainings through healthy outcomes from positive experiences out of Tufts, and to be able to learn more. Although this campaign was live in the summer of 2023, the webpage remains online, and we also did a secondary campaign that sent information to community organizations that we identified and linked them to this website and information about how to share all of this information with families. So that wraps up the first of the two campaigns we hope to share with you today, that are tools and strategies you can use to improve mental health conditions and reduce poverty. So I'm going to pass it over to Claudia for some background and to take a look at our second campaign.
Thanks, Lindsay. One more slide. And so I will talk about our paid family and medical leave campaign in Massachusetts. So as many people know, the research has shown over again that the social determinants of health, economic benefit side of things, really improve health outcomes, and particularly paid family and medical leave being one of those economic benefits amongst others that is shown to have great impact on family and child development, well-being, financial stability, etc. Some of those health outcomes listed here we can see, amongst others, reduced low birth weight and preterm birth, especially for unmarried and Black mothers, decrease in infant, neonatal, and under 5 mortality rates, reduction in maternal depressive symptoms, increase in breastfeeding, improved infant attachment and child development outcomes, amongst others. And so we know to date, 13 states have passed paid family and medical leave laws, including Washington, D.C., and many others are considering this economic strategy as a way to support families and children in their states. And so what paid family and medical leave looks like in Massachusetts, we have 2 types of leave. We break them into medical leave, which is caring for one's own medical condition, and then family leave, which covers 3 different types. Bonding leave, which is leave to take care and welcome a new child into the family, including adoptive or foster children. Caring leave, which is to care for family members' medical condition, and then active duty leave, military families. Taking bonding and caring leave, you get up to 12 weeks of paid leave. For medical leave for one's own condition, you can get up to 20 weeks. And then there's a combined 26 weeks in a benefit year of leave between family and medical. With this law has also come job protections. Employers are required to maintain an employee's health insurance status at the same level they were before they went out on leave. Also required to maintain the hold the employee's job and return that same job or a job equivalent job upon return from leave, as well as same salary, accrued benefits, and credit years of service with the employer. Okay. So here is our campaign. The Mass Department of Public Health has had an existing and standing relationship with the new Department of Family and Medical Leave in Massachusetts, the state department that was stood up to roll out this new benefit. And through the course of work together, we are always focused on equitable rollout and implementation of the new paid leave campaign. And something that we had talked about really was a real need to increase awareness. There's confusion when a new benefit rolls out. Not everybody's aware of it or aware that they're eligible for it. There's confusion, particularly as it came out during COVID. Was this a COVID benefit or was this something new? What's the difference between Massachusetts paid leave and FMLA? And so we really felt this was an opportunity to join together between 2 state agencies to do yet another campaign to raise awareness. Given that the paid leave benefit is extensive, we needed to focus on one particular group. And so we chose families welcoming new children, given particularly as our CDC grant focuses, as Lindsay described is really on young children and families. So that was our primary focus. We really wanted to make sure we were reaching our primary populations, families that are disproportionately impacted by structural racism and other inequities, folks that have historically lower rates of taking up benefits or taking up paid leave in other states that had previously rolled out this benefit. So we worked with our marketing company to really make sure that we were going to be able to get this campaign out to the primary folks that we really wanted to see this campaign, and really be able to increase awareness and knowledge that this was available to them. So we looked at demographic indicators. We looked at birth rates. Where are the highest birth rates in the state? You see that, age-wise, 20 to 34-year-olds have higher birth rates. We looked at them geographically where those groups were stratified across race and ethnicity, around first-time mothers, poverty levels, and some other indicators to make sure we were really having a statewide campaign that was tailored to our primary participants. So this enabled us to have a campaign that was statewide in geographic pockets across the state. And we were able to roll out the campaign in 5 languages: in English, Spanish, Brazilian, Portuguese, simplified Chinese, and Haitian Creole. So being able to mirror the same languages also that our Department of Family and Medical Leave has the online application in those 5 languages as well. And then working with our marketing company, again, tailoring the types of communication channels to our primary populations for the campaign. We had billboard ads up on highways. We had Google display ads running banners across Google pages, various social media, radio ads, print ads, and TV ads. And again, really making sure that we were looking at the latest information around what types of communication channels worked best with different populations. We knew some groups were heavy into the radio, so we wanted to make sure that those populations were served by radio amongst others. So we really were tailoring our approach. And again, our campaign images right here, amongst many other images. Our slogan was "Pay time off when you need it most." And our representative images are really important for us. We wanted to make sure that our images displayed LGBTQ families, families of color, families welcoming newborns, families welcoming adoptive or foster children, to the best of our ability without obviously stereotyping or having an inappropriate image. So you can see here some of our other campaign images. We also had a landing page that was available through a QR code on our campaign. We know sometimes state websites aren't the easiest to navigate, so we wanted a landing page that could really direct people into how to understand leave when welcoming a new child. And then some direct links around eligibility for the different types of leave and transitioning from medical to bonding leave. And I can go into that in a minute. And again, this was also available in the 5 languages that our campaign was. So with a little bit more about that landing page, again, some more campaign images. We couldn't highlight everything in a one small slogan on a campaign. So the bonding the bonding page gave us more options to explain in a little bit more detail what we really wanted people to know. That yes, foster and adoptive families are eligible for this leave. In addition, that birthing people, mothers who are giving birth, are possibly eligible for both medical and bonding leave. Something that was a bit confusing that we had heard throughout our work together, that people didn't realize that you could work with your medical provider to request medical leave for the delivery of the baby, as well as pair that with bonding leave for bonding and attachment purposes. So you could have those 2 leaves together to extend that leave. And that landing page gave us that opportunity to explain a little bit of that. We also had other links to other economic benefits for families, how to apply, other videos to help people understand, and where to go for questions and answers. And then the final tool that we had through this awareness campaign was working with our marketing company to develop a community toolkit. So this was a PDF document that we were able to send out wide across our networks to community partners, healthcare providers, anyone who might be able to be interested and able to help us spread the word about the paid leave campaign. And so the toolkit was incredibly user-friendly, also in those 5 campaign languages, and provided people easy access to click right in the PDF and download the images and download scripts around how to post something up on social media, already kind of tailored for people. They could tweak it as they needed, but ready to go images and scripts for people to post. Flyers were attached, fact sheets, WhatsApp messages, trying to give people a variety of different tools to be able to spread the word about the paid leave campaign in Massachusetts. And thank you, that's our presentation. And we just have our little ending slides, and I will turn it back over. Thank you very much.
Thank you so much, Lindsay and Claudia, for that fantastic presentation. As a reminder to participants, please take a moment to post any questions in the chat, and we'll save time for Q&A at the end. With that, I'll turn it over to Kelsey from the Michigan Public Health Institute. Kelsey, you can take it away.
Thank you so much, Caitlin, and thank you all for being here today. I'm excited to talk to you a little bit about some different things we're doing both in provider approaches as well as system or really cross-sector approaches to supporting individuals and communities, particularly those experiencing mental health and poverty. So quickly, just to acknowledge that I do not have any financial disclosures to report at this time, but the interpretations, conclusions, and opinions expressed in this presentation are mine and not those of my funders or organization. And to tell you just a little bit about myself and the Michigan Public Health Institute, my name is Kelsey Sela-Hamrick. I am a senior research scientist as well as a trained clinical psychologist working at the Center for Strategic Health Partnerships of the Michigan Public Health Institute. And while we're not a public health department or state or local public health department, we work at the intersection of public health, including kind of pulling together public health professionals, researchers, community members, clinical service providers, all together in order to improve access to high quality healthcare. As well as in my role at the Michigan Public Health Institute, I also serve as the director of the Michigan ACE Initiative, which is a cross-sector collaborative focused on preventing and mitigating the impact of adverse childhood experiences. And if you'd like to learn more about our work, some of which I'll talk about today, you can go ahead and follow the QR code or visit myace.org to learn more. So the agenda for my part of the presentation today is first to review a little bit about how mental health and poverty are associated, and then discuss provider training approaches that we've been using to support individuals experiencing poverty and mental health conditions. And then finally discuss cross-sector approaches to supporting individuals, communities, and families, and really give you all some ideas about what you might be able to do in your states and in the different public health sectors you support and work with. So how are mental health and poverty associated? So to give you some numbers, right? Starting with some numbers, these are from two different sources, the National Survey on Drug Use and Health and the National Survey of Children's Mental Health. And what we see is in general, individuals who are living below the poverty line are experiencing significantly higher rates of mental health conditions. So if you look at some of these first bullet points on this slide, around 21% of people ages 18 or older have a mental illness in the past year. And 6% have a serious mental illness or SMI. And in those who live below the poverty line, approximately 25% or 1 in 4 adults have a mental illness or SMI. So significantly higher rates we see, which is not necessarily surprising to any of us, but important to acknowledge. This is also true when we're thinking about children who are experiencing poverty and mental health conditions. 1 in 6 children have a diagnosed mental, behavioral, or developmental disorder, and those children living 100% below the poverty line, 1 in 5, or approximately 22%, have a mental, behavioral, or developmental health disorder. And there's a lot of literature out there that really explains why this is and why we see higher rates of mental health conditions for those who are experiencing poverty. And I put this quote at the beginning of this slide because I think it's really important to emphasize that poverty is both a cause of mental health problems as well as a consequence. And so if we look first to the right-hand side of this slide, we see a lot of different factors that are at play for those who are experiencing poverty that might lead to increased rates of mental illness. And so this can include increased stress, increased financial stress, lack of access to nutrition, lack of access to quality health care, poor housing and neighborhood experiences, increased exposure to trauma, violence, adversity, increased ACEs or adverse childhood experiences, and a reduced access to the social capital or safety net that many of us rely on when experiencing financial stressors or other stressors. At the same time, when we're looking at the left side of this slide, those who are experiencing mental illness might experience a lack of employment or reduced poverty related to their mental illness, especially those with more severe mental illness that might impact their functioning. Similarly, you might see increased functional impairment in different aspects of everyday life. So this could include employment, this could include ability to take care of oneself, this could include academic performance. Oftentimes you see increased isolation, and again, lack of access to care and an increased healthcare expenditure for those experiencing mental illness. And all of these things then put someone at higher risk for poverty. And this is how what a lot of literature has discussed, the vicious cycle begins around how poverty and mental illness are connected. Lindsay and Claudia did a really great job explaining how social context, environmental context, and economic context of where a child or an adult is living is going to impact their experiences of ACEs or other violence. So I won't go into too much detail on our ACEs pyramid, but I do want to kind of make sure I acknowledge that those social conditions or local contexts for those living in poverty are linked to an increased onset of mental illness, including SMI and SED. So SMI being serious mental illness among adults and SED being serious emotional disturbance among children. You'll also see a likelihood or an increased risk for more intense or severe symptoms related to mental health. Less access to care and less access to social and economic supports, and of course, increased risk exposure to trauma, violence, crime, and unstable housing. So as we're thinking about how mental health and poverty are associated, one of the things my organization and my work does is to think about how we might be able to train providers that are working with individuals experiencing poverty, mental health, or both, in order to impact the care that these individuals receive. So when we're thinking about provider training, the first thing we want to think about is who might be the right providers to train. And there's been a couple different groups of providers we've targeted for training in this area, and they're primary care providers. So this includes physicians, nurses, advanced practice providers working in a primary care setting, specialty care providers. So again, medical providers in specialty healthcare settings and large health systems, behavioral health providers, and community health and peer support workers. And when we're thinking about the why behind increased provider training, our focus is really on educating providers to understand mental health in its root contexts. And by doing this, we aim to reduce stigma for those who are experiencing poverty, as well as stigma around experiencing mental health symptoms, as well as hopefully improve providers' ability to recognize the signs and symptoms and identify needs in a collaborative way with the patients they're working with. So when we're talking about the topics we've kind of focused on in provider training, there's a few we've focused on. One is just training around understanding poverty and how it impacts mental health in order to increase that awareness and decrease stigma. We've also focused on some more specific approaches to providing care, including culturally responsive care, trauma-informed approaches, effective screening approaches, screening for things like social determinant of health needs, higher risk for ACEs or other traumas, working on recognizing the signs and symptoms of mental health conditions, especially for providers who aren't trained as behavioral health providers, and also providing brief interventions in session, again, especially for those medical providers who aren't specifically trained as behavioral health providers. So we use a couple different training methods that have been really effective. Some include live webinars that provide different types of continuing education credits. And we've also been able to use continual quality improvement processes and the credits such as MOC4 credits for physicians, in which providers are able to go through a training process and implement a QI process to help improve the care that they're providing to this population. Another training method we've used that has been really effective in both increasing awareness and knowledge, but also in increasing community and networking among providers is the Extension for Community Healthcare's model, or the ECHO model, which is an all teach, all learn model where providers come and are presented by a content expert and then also present a case concept or a case presentation in order to share the work they're doing and get feedback on their clinical practice from their peers as well as from the content expert. Another thing we've been doing to make sure we're really able to reach those we need to reach is partnering with different systems. So large health systems as well as smaller individual health clinics. We've seen a lot of benefit in targeting some of these smaller individual health clinics that oftentimes don't have large infrastructures or universities connected to them, and they've been very thankful for these trainings, as well as working with health plans and seeing when health plans are able to provide training to their providers in a more direct way. So a couple examples of some of the trainings we've done can be found online. The first up at the top is trauma-informed care in the medical genetics clinic. This is an example of a specialty healthcare provider training focused on individual providers working with children with special healthcare needs, genetic conditions, and we were able to provide training on trauma-informed approaches, as well as different resources and step-by-step guides on how to implement this type of care in a clinic. And then at the bottom is another example of our partnership with a health plan with the Upper Peninsula Healthcare Solutions organization. And with them, we were able to both develop an ECHO series for providers across the UP, which is a rural area serving many different low-income populations. And in that training, we were able to do an ongoing ECHO series as well as an in-person all-day trauma care and resilience conference where providers of all types were able to come and practice skills, learn different skills, learn how to recognize signs and symptoms of mental health conditions in the people they were working with. So the next section I want to talk about briefly is how cross-sector approaches can support individuals, families, and communities. And when we're thinking about cross-sector approaches to supporting mental health of individuals experiencing poverty, the underlying thread in this work is improving access for underserved individuals, families, and communities. And we can do this through reducing barriers to accessing care, improving trust in healthcare and public health systems, and increasing communication and collaboration between the sectors. And for the sake of time, I'm not going to spend a ton of time talking about these different projects we're working on, but I provided a couple of examples of the different cross-sector approaches we're using really to meet people where they're at and increase their access to high quality care. So the first area is around primary care work, and we're focused on supporting and developing integrated models in primary care, as well as enhanced pediatric care models, such as the SEEK framework, which stands for a safe environment for every kid, and enhanced primary care models serve as a way for primary care providers to identify children and families in need early in the process and make a referral or make a connection to a wide range of different types of community support services, behavioral health support services, and other kind of social support and safety net services. And an important part of this work is that while someone might be experiencing poverty and mental health conditions, behavioral health may be only one potential referral a family is interested in. There might be other referrals that might be a better fit or more desired for the family. And when we're thinking about these primary care interventions, we can enable or put in place systems where providers can connect to a range of referral networks, which brings me to my second point on this slide around really enhancing referral networks in communities. Some of the work we've done is called enhanced trauma-informed care referral networks, where we identify a range of organizations across different service sectors that are dedicated to providing care in a trauma-informed way. And again, this helps us both address mental health conditions, but also those root context of those mental health conditions. And finally, on this last slide, I want to talk briefly about some of our community-based and early child care-based approaches as well. In the community, again, we're very focused on meeting people where they're at. And one of the most effective ways to do that is to find community leaders. Oftentimes, these may be faith-based leaders, and work with them on how to increase access to the services or supports people need. We're currently conducting a faith-based harm reduction pilot where churches and other religious organizations are implementing small behavioral health and other social service programs within their religious communities. We're also right now, again, kind of thinking about those training opportunities, leading a faith-based learning collaborative where different faith-based leaders in communities, particularly communities with high rates of poverty and mental health conditions, are able to learn a wide range of skills about how to support people experiencing poverty and mental health. In the early childcare based approaches, we're focused on expanding a lot of the existing programs that are already in our state, including home visiting and early childcare providers, to ensure that the people who are providing these services have training, as well as we're able to expand these services to meet the needs of more children across the state. And with that, if you have any questions, you can email me or visit myace.org. And here's some references, and I believe I'll hand it back to Caitlin.
Thanks, Kelsey. Really appreciate that presentation. With that, we'll now begin our Q&A portion of the webinar. Feel free to share any questions for Lindsay, Claudia, or Kelsey in the chat, and we'll, pending time, try to get through as many questions as we can. For starters, Claudia or Lindsay, let's get them lined up as well on Spotlight. Perfect. What challenges has your team encountered related to positive childhood experiences and financial stability public awareness campaign, and how did you overcome them?
I can start us all, Lindsay, if you want. Challenges, I think, kind of what I referenced earlier is you want to be able to reach so many people, but you can't. So and with any one particular awareness campaign. So it's just really, I identifying a priority group or geographic area, or some way to narrow it down, because even though with those particular opportunities you want to be able to go as big as possible, to make it the most effective, you have to kind of bring it down to a more manageable level so that your message doesn't get lost in your campaign. So I guess that'd be one kind of challenge we had, was thinking about how to start to narrow it down and not and make the message still meaningful without losing that.
That's helpful. Lindsay, anything that you would add?
No, I was going to say that exactly from the PACES campaign was what I felt was most challenging.
Makes sense. Thanks both. Kelsey, for you, how do cross-sector approaches help in supporting individuals with serious mental illness or children with serious emotional disturbance?
So when we think about individuals with SMI or SED, part of SAMHSA's definition of serious mental illness or serious emotional disturbance is not only is someone experiencing mental health conditions, but they're also seeing or experiencing pretty significant impairment in different domains of everyday life. And when this is occurring for someone, it can be really difficult to navigate complicated systems, right? And then we're thinking about families trying to navigate multiple complicated systems, right? And so one of the things we're doing with our cross-sector approaches is, I think you've heard me use the term like meet people or meet families where they're at. Whenever we can meet them where they're at and connect them to the services we need, that's just one less stress, one less barrier these individuals and families have to being able to get the care or services they need.
Kelsey. Claudia or Lindsay, do y'all have a recommendation for other jurisdictions that are considering a paid family medical leave public awareness campaign?
I can take this, or also Lindsay can talk about, for those who are considering adverse childhood experiences or positive childhood experience campaign, really. Recommendations for those states that do have paid leave, or even just considering other economic benefits. I think just kind of the standard representative imagery, making sure people can see themselves in the campaign, easy to understand slogans, and I think partnering with a great marketing company who has the market research around what types of communication channels work with what populations you're trying to reach, and being able to tailor your messaging to the appropriate channels to the appropriate audience in the way that you want to. So I think those are a couple of key takeaways that I learned through our process. Lindsay, I'm going to share what you learned in the PACES process.
Yeah, I think talking about both of our awareness campaigns next to each other is pretty nice, because PFML, at least like how it's written into law and who's eligible, is like pretty clear. It's just a matter of getting that message across for eligibility. But for positive childhood experiences, because it's so much newer in the research, and ACEs were so kind of well established, and a lot of people understood, at least the first CDC Kaiser study, that trying to determine at a department level, or at least our unit team level, like how we wanted to define positive childhood experiences, but also bringing in that this was meant for parents, caregivers, and community members, is if we say positive childhood experiences, really what does that mean to them? So we had the same marketing agency for both of the campaigns, which was really helpful, but they dove in and did a lot of focus groups to understand from families what positive childhood experiences really meant to them if they heard that word. And we were able to really build our messaging and the resources that we would provide individuals who are going to the website with. So, and I think being ready to have all of those resources and really getting that large toolkit up on the website and be able to share it with community organizations was also a key practice, because it's like, okay, PACES enhances well-being, but like, what are PACES, or how can I get those specific resources I need to then be able to have more time in my schedule to be able to have positive childhood experiences, or what are some things I'm doing now that we can engage in that too. So yeah, the focus groups, defining it with families, and then having an extensive resource list for families who are going to the website.
Makes sense. Thank you. We did receive another question from a participant. Are either state using a coordinated care platform like Unite Us to reduce re-traumatization and provide wraparound support? And if so, has that service been beneficial for participants? And let me know if you want me to Kelsey, I don't know if this falls more into your domain.
I was about to Google Unite Us to make sure I know exactly what that is. We do use wraparound services in Michigan and other like care navigator roles in order to kind of support that closed loop referral system, especially when I was talking about our trauma informed referral networks. All of that goes through an organization that can kind of make sure that referral actually happens and those connections are made. I'd have to look up a little bit more about Unite Us and exactly where that fits in. I'm not sure that specific program is something we're using.
Same for Massachusetts. I'm not so familiar with that program, but we do also have wraparound services, and but there are sort of multiple systems out there that do sort of those closed loop referral networks, or but there isn't this like a statewide one. Sometimes they're based out of our Medicaid program, or sometimes they're based out of a hospital network, or sometimes they're based out of the community. So those kind of coordinated intake and referral systems are often a little bit more piecemeal and not as coordinated. We also don't have a county health system in Massachusetts. We have a state health system and then local cities health departments. So we have more of a decentralized process in our state. But there are sort of a lot of good things happening, just more in kind of in more decentralized pockets.
Our participant said, yes, it's a closed loop referral that can be used across systems. So thank you. Another question, and I'm just checking the chat to make sure nothing else has come in. What policy strategies have your states leveraged to reduce poverty and improve mental health? Kelsey, do you want to start?
So I think I'm going to talk about one policy strategy that is not specific to my organization, but that has been a big deal in Michigan recently. If you have all maybe have heard of it, it's the RX Kids program, and providers are now kind of under the umbrella of provider training and resources through health systems. Providers are now in certain communities in Michigan, specifically Flint and Genesee County, able to prescribe cash prescriptions to low-income families as a way to support their needs. And we kind of understand that, like Lindsay and Claudia were talking about, financial security is a really important first step before we can really address a lot of the other needs families are experiencing. So that was a big kind of policy focus and thing that's happening in Michigan right now. I won't take credit for it, but it is something very cool in Michigan that is occurring.
Absolutely. Claudia or Lindsay, anything you would add in terms of work happening in Massachusetts?
I just looked up, besides the obvious earned income tax credit being one of the most successful anti-poverty programs across the country, Massachusetts recently passed a new child dependent tax credit, which is expanded eligibility to families with youth 13 and under. I believe that's the age. I'm not entirely sure, but it gives families a roughly $310 per child per year, and next year will go up to $420 per child per year. Also, other dependents are eligible for that credit, and there's no cap on the number of children in the family. So that's been a recent policy win in Massachusetts and huge benefit for families. And there's also some universal basic income or guaranteed income pilots happening across the state, not at the state level, but at the community level or at the nonprofit level. So the city, just lift up one example, is the city of Cambridge has entered a second year of their program. It's not universal, but they have income eligibility for that universal basic income cohorts. And they've really started to look at some of those outcomes and see some real positive, exciting outcomes coming there. So, and they've been able to work with the state's Department of Transitional Assistance to make sure that income pilot doesn't affect their benefits, so they don't experience those benefit cliffs. So those are just to lift up two of many other exciting kind of opportunities that are happening in Massachusetts.
Fantastic, thank you. Well, I think we just came up on time for Q&A. However, encourage the participants to please reach out to us if you have any additional questions, and we'd be happy to pass those along to the presenters. And then thank you again, Claudia, Lindsay, and Kelsey, for joining us today and taking the time to present on the amazing work that's happening in your states. And thank you for the participants for joining us. And we look forward to hopefully interacting with you in future work, whether you have any technical assistance requests, comments, or questions. And we value your feedback. So please take a moment to complete the survey that will pop up at the end. I will turn it over, I believe, to Bailey to close us out.
Wonderful. Thank you so much for a fantastic presentation. This does conclude today's session. You may now disconnect.